My name is Hannah Yoon, and I graduated from the New England College of Optometry in 2020, and I'm currently the Contact Lens Fellow at the University of Illinois at Chicago. Today I'll be briefly discussing a case of patient RL, who is a 71-year-old male who was diagnosed with herpes zoster keratouveitis in the left eye in 2016, and since then has had several sequelae including neurotrophic keratitis with recurrent non-healing epithelial defects, as well as uveitic glaucoma for which he had an OMED valve placed in 2018. He's completed an 8-week trial of Oxervate, is status post lateral tarsorrhaphy, and is currently using serum tears, erythromycin ointment, artificial tears, brimonidine, preservative-free Cosoft, and Valtrex. Pentacam revealed an irregular multifocal cornea with visual acuity of 20/50 by refraction. This is a slit lamp photo of the patient's left eye, and here's a closer look at the patient's superior valve. And the patient also had a 1 millimeter round epithelial defect nasal to the visual axis, and as expected, he did not complain of any eye pain. When we placed a conventional scleral lens on the left eye, it showed conjunctival impingement over the valve. We could also appreciate that there was conjunctival tissue spilling over the front surface of the lens. After discussing the options with the patient, including microvaulting and corneoscleral profilometry, we decided that an impression-based scleral lens would provide the best fit given the regularity and broad area of elevation of the conjunctiva above the valve. As you can see here, the impression-based scleral lens is extremely well aligned to our patient's eye and provided an excellent outcome. The role of contact lenses in this case was twofold. For one, we were able to improve the patient's vision from 20/50 to 20/20 with the scleral lens, and we were also able to heal the patient's epithelial defect by using an extended wear silicone hydrogel bandage contact lens with prophylactic antibiotic drops while we were waiting for the scleral lens to arrive. In the long term, we expect that the scleral lens will both protect the patient's ocular surface and maximize his visual acuity. Our patient was incredibly impressed by the ability to create a one-of-a-kind lens that fit his eye and his eye only, sort of like a fingerprint. One of my favorite parts of the fitting process was his reaction to seeing the lens for the first time and being able to feel the lens himself so that he could understand how irregular and asymmetric his corneoscleral curvature was and could understand why fitting his eye would have been challenging if we did not have options to highly customize a lens to match his exact eye shape. The process of designing and fitting a lens using the mold of a patient's eye as a framework is incredibly exciting, not just for the contact lens fitter, but also to the patient. And I love being able to share with patients about new technologies and advances that have been made in the specialty contact lens field. So the main takeaways from this case are to take caution to avoid harsh touch of the scleral lens landing over a glaucoma drainage implant, and to consider an impression-based scleral fitting to create a custom imprint of the corneoscleral curvature if a conventional scleral may be inadequate. And I'd like to thank the Academy section on cornea, contact lenses, and refractive technologies for the opportunity to present, and Dr. Shorter for her guidance on this case.